I've met a few of you already. I have to say that I've spent a few days in and around Wellington. Clive and I and others and Sean have been around some of the services and obviously the programme, which we're here to sort of really think about, introducing quality improvement to mental health services really. Starting pretty well, I would say. I'm very impressed. And what's an expert? An expert is somebody from elsewhere really, a guy from out of town. That's me. I'm an expert only in that I, for the last 5 years, have led the Scottish Patient Safety Programme in mental health, which is doing very similar things to what you guys are trying to do. So what I bring is some experience and some ideas about what you may or may not wish to do, and certainly some of the things that you would want to avoid doing, some of the things that we did wrong. So this is a chance to sort of have a think about that. So I think I've probably told you who I am. So I'm a psychiatrist. I've been involved in quality improvement work, both in terms of this particular patient safety work, which has actually taken off pretty well in Scotland. And before that, I was involved in a slightly different methodology, but a collaborative which looked at trying to reduce psychiatric readmissions in Scotland. And it was successful, but probably not that much to do with the collaborative, if you ask me, because things were moving in that direction anyway. So, and why am I here? Well, as I said, as I just said, we are just a bit ahead of you, actually. We're just a few years further down the line of the same sort of work. And what might I bring? Well, here's where I've put a few slides up. You might have seen this. That's where I came from. This is where we are. Long way. Other things that we have in common, again, rugby. Teamwork, though, I suppose that this is what I'm trying to say with that slide is that the scale of things in Scotland, and you're a lot better at rugby than we are, but the scale of any issue is very similar. The population's similar. Yes, you're more rural than us in some regards, but we've got big distances and islands that are far away from any centre. So the issues of providing health services or any service in Scotland compared to New Zealand, I see lots of similarities. You have 20 different provider organisations. We've got 14 health boards. We have got a level of coherence up to a point, which maybe is a challenge for you, but that's something to think about. What else in common? Well, we've got really nice scenery, and that's Wester Ross, which makes me remind me of my partner in crime, who's been over with me before, and who's also linking up with your programme. Jonathan is from Wester Ross, and that's a picture from his granny's window. The other one is, you may recognise it from, I think it's the South Island, is it? It's in so again, nice scenery. On to the real business. So again, forgive me if you've heard this story before. So what were we trying to do in mental health services in Scotland in terms of patient safety? I guess we were challenging some assumptions. And the main assumption around mental health services is that if you're really ill and you're quite distressed and disturbed, actually, yeah, we have to really restrict you. You probably have to be in hospital, you probably have to get jagged, you'll be detained under the Mental Health Act, you might end up restrained and held down. And that's maybe just part and parcel of what happens. And we're talking here today with colleagues here in Wellington about seclusion, which we just never had a culture of secluding people, i.e. taking them away from where they are and for their own safety, putting them somewhere else. But again, it's changing already, I can tell, but there is, or has been, I guess, a culture where, well, it's an inevitable part of what you do in mental health services. So, anyway, you recognise this guy? Neither Scottish nor New Zealand. Far too handsome, no. Well, this is Ayrton Senna, the best Formula 1 driver there ever was, who died, of course, tragically in the same weekend, 40 years ago? Near enough, 30 odd years ago, as another Formula 1 driver. And so what happened then? Well, again, this assumption, and this is where the analogy, which I think is a reasonable one, that people, young men driving at nearly 200 miles an hour around the track will occasionally crash and die. And these two guys did. But, you know, some leaders, and I guess most of you have got leadership roles, I think. Leaders decided that just wasn't acceptable. Actually, you can't assume that's going to happen. Surely we can do something to make Formula 1 safe without it becoming totally boring or whatever. So they made a decision, and what happened? Well, from that point, there was one death, tragically, which was an anomaly, just in recent years. a piece of machinery was in the wrong place, the guy died. But otherwise, there have been no Formula One deaths since then. And the whole culture, it was achieved through lots of changes in the car, changes in the support, the access to medical services, etc., etc., etc. But it caused a huge change. So culture change, challenging assumptions, is possible. So I know that you maybe had a bit of pushback around zero seclusion. Oh my goodness me, that's impossible. Well, actually, going about it the right way, and I guess this is what we're here to think about, then it is possible to change culture and to have really major changes in what happens. So, and again, in healthcare, is there a similar experience? Well, again, Professor Leach, Jason, our clinical director in Scotland, who maybe some of you have met, standing in front of a graph, showing the fact that when they set themselves a very challenging target of reducing the hospital standardised mortality ratio by that sort of level, they exceeded it and set another target. So, and that was achieved. Jason tells stories of turning up at meetings with intensivists and anesthetists and saying, we think pneumonia, ventilator-acquired pneumonia isn't inevitable, and they said, yes, it is, etc., etc. But through a number of strands of work, and starting small and building up over 5 years, they achieved a major result. And again, challenged some assumptions. So the success of that program, which started maybe 12 years ago, led to Scotland adopting a number of other programs built around patient safety, utilising quality improvement methodology at the coalface to try and change things in a dramatic and meaningful way. So that slide shows the range of pieces of work. So it was work introduced in child health, in primary care, and in mental health. And the aims around mental health, it mentions seclusion, although there was only one hospital where we had it, which is an interesting thing to discuss. But certainly reducing violence, self-harm, and restraint, which is obviously an intervention really, were the key aims. And as I commented earlier today, one of the interesting things was when we looked for the evidence about, well, those are the things which we think we need to reduce, and we asked the stakeholders, the consumers and the providers, where would you start? We came up with a number of work streams, including medicines management. People said that medicines are an issue that we should be better at managing, and therefore more safety conscious around medicines. Reducing violence, restraint and restrictive measures. Patients, service users told us that those were very unpleasant things to experience or even to witness, and therefore that we should start in inpatient settings reducing those things, and in addition attempting to change the overall culture. So the kind of work streams that we have compared to the ones that you guys have developed are actually very broadly similar, although they came from a different consultation, if you like. So 5 years down the line, and I can show you a few slides a bit later, we have successfully introduced quality improvement methodologies, keeping it pretty simple, into every mental health facility in Scotland. I think you're in the process of doing that too. We're supporting that work with a small central team, small in that it's me, Jonathan, 2 or 3 others, and Jonathan's moved on now, so it's me and another Jonathan, because it makes life easier to keep the Jonathans. Supporting people at the front line in the boards, testing out things in a one step at a time way, and we have seen areas, not everywhere, but areas where we've got very significant improvement in those outcomes. So, now, given the small numbers, this is where I thought it would be good to actually get you guys to do a bit of thinking and work. And it might be you want to just have 2 tables, but with the, in your small groups. People are apprehensive about this kind of thing. People are sometimes hostile about it and think, okay, it worked in Formula One, it worked in acute medicine, it worked in Scotland, but it won't work here. So please have a discussion around the next 5 minutes or so about what you think the key challenges are. Maybe stick it on a post-it note and stick it down, and then we can discuss what those challenges will be and how we can approach them. Okay?
I think about the possibilities rather than the barriers and the challenges, particularly, and also that the importance of publicising the quick wins as well. So, you know, for example, we already have units in New Zealand who have achieved zero seclusion on a month by month basis. Yes. That's motivational for other similar units to hear that. We have units in New Zealand who have gone from 6 seclusion rooms to 5 seclusion rooms to 4 seclusion rooms. That's motivational. We've got a child and youth unit that are saying they'll close their only seclusion room by the end of 2018. That's motivational. So all of those things to make sure that they are publicised and spread, because it all helps in the building of the case for, yes, this is New Zealand, yes, we know this is challenging, yes, we know that you are really busy, and you know there are lots of factors, but these things are possible and they're achievable, and you know if we work together and we use the quality improvement methodologies, we can achieve it together.
We raised the issue about equity or inequalities that at the moment it's hard to know what any methodology is in regards to how you address those issues. So if you are going to bring in a quality improvement program, you really do need to look at it, because we already know that there are some parts of your client group, the people that you're serving, who are actually missing out. And also there are issues to do with how much money is generally around in either secondary services or in the community, and also the workforce, because say if you were wanting to address the workforce issue, we already know that there aren't enough Māori nurses working in the mental health area, and for those that are generally working there, they're older and they're likely to be retiring in the next 10 years. So there are, you're going to have to work out what your approach is and then how you're going to tackle all those issues.
We do have an acute unit that has reduced their seclusion of Māori below non-Māori, and they're using some approaches that are quite effective. Now they're looking at how they apply some more targeted approaches to Pacific populations.
It definitely is increasing the Maori workforce. In fact, you know, we're asking those questions today about the recruitment of Maori nurses, but it's also about increasing access to cultural input. So sometimes where you can't necessarily recruit the permanent staff, you can access cultural input so that if need be, you know, you can arrange, for example, for the person to be to have a mihi on their arrival into the ward, for example, and therefore they'll feel that this environment is taking my cultural needs more seriously, etc. So yeah, it's quite interesting when I visited one of the DHBs in the South Island, and I said to the charge nurse there, if I gave you a magic wand and you could wish for anything, what would it be? And I expected her to say more nurses, and actually she said, what I would want is a cultural member of staff and a peer member of staff. I'd rather have them than many more nurses. It's not more nurses I need, it's actually those specialisms that I feel is really going to make the difference.
Wow.
When we talk to the child and youth service about how they manage some of the more complex, they believed that by having 24/7 whānau presence made a huge difference to those young people that were particularly getting through methamphetamine intoxication, and by opening their doors to families, they found that collaboration with family made a huge difference to the recovery of the individual.
Part of this this issue around inequalities is also recognising that it actually takes more resource for Māori services, like to have the cultural component and also the clinical component and the support component. You know, you need all those sort of components, and one person doesn't have that all. You know, I'm talking about maybe having cultural workers or kaumātua there, and you know, and working alongside clinical people. I mean, that does go on, but it needs to be at a greater pace.
I'm just going to add something. Sorry. We actually had all of these things because Simon was in the videos for the Needs Assessment Service Coordination when it was originally set up. that Wee Keelan actually went around the country publicising, which was a newfangled damn thing for the ministry years ago, about how we were going to change assessment. All those things were actually in place at Te Whare Mārie, but over time, it's actually been whittled down. And I could look at all the Māori services and say exactly the same. The people who drove it have moved on, and the people who've come in, it's just different. And so cultural practices that you guys probably use, like de-escalating people by playing a guitar and having waiata so that people always were in a positive mood, so that instead of us coming up to put our hands on people and saying, can you quiet down, everyone respected those types of practices, because it was an opportunity you could have your say, but then we were going to return to, in my experience, rangi Māori, so people knew that. And so that's not happening in a whole lot of places, whereas it would have been just first, the first thing to move towards, because that's how you calm people down when you're having disagreements on a marae, because we consider that usual. We're going to disagree, but when we sing waiata together, we're coming together again, and it's over, and so we can move on. So yeah, there's been an erosion of a lot of these things, and hence the increase of seclusion.
So I think that's a very well put point. That kind of brings me on to the next thing. Yeah. Because I think one of the issues that you're really talking about there is, well, I mean, it's loud and clear, and I am an outsider. I've just come in a few days ago. The whole equity one. So for this programme to have credibility, and I think it sounds to me like it is front and central of what's going on. It is for everyone, and it's about QI improvement, which will help to address the equity issue. So I think that's loud and clear. I think that's controversial, is it really? Yeah. But I think the second point you're making is, and again, one of the other challenges is once you get enthusiasm and people doing this stuff and going, how do you sustain improvement? Spread it, in fact, and sustain it, and that's the kind of challenge that we're facing. We're 5-6 years in. We have seen areas with big gains, other areas that I'm engaged as well. How do we ensure that as we move to newer areas, i.e. outside hospital, and working with community teams more than inpatient services, how do we maintain the gains that we have and consolidate them? Which is, I'm sure you have thoughts about that, but I'll park that one. So you're talking about an issue, but also about maintaining change and improvement once it's established. Indeed.
It's once those, if those people go, then so does the kind of drive. And I wonder, I've thought a lot about this. I wonder if this is a New Zealand thing, because it does feel like, particularly in the UK, because there's so much structure kind of around the NHS, that it's less open to that kind of fluctuations and having the right person in the right place at the right time. And while that's important, I think that often that happens, one person leaves and then the whole thing just kind of fizzles away. And that seems to happen quite a lot.
Yeah, and in fact, so I guess in my opinion, one of the benefits of a national programme where you continue to do it that way, where you bring people together as a collaborative and share what's going on, not only helps with the spread and the sort of embedding of good ideas, it also maintains things, and you've got to keep looking at your data. So you've got to keep identifying what's going on. So the collaborative model, clever people from Boston who invented it, got it kind of right. This idea that the work's done here, but you have to come together to then share it, spread it, and to sustain it, and you have to keep doing that. Perhaps at a different intensity further down the line. Right, okay, so another few minutes just thinking about, why is this a better approach than others? Maybe we've answered that already, but can you think of any particular reasons why a QI approach has benefits over other ways of trying to redesign or improve services?
So in terms of benefits of quality improvement approach, it's like a roadmap. And so that's helpful for everyone, and it's about a system as well. You get the evidence, so you'll be able to measure progress as you go along. If you
And
have
quite quickly. And quite quickly, it was the point you made, yeah. So the
Oh,
evidence,
cool.
evidence is, yep, sorry, yep.
Yep. Important to have the staff involved, so you get a ground-up approach. So it's got to be driven from two parts, really. Leadership, which actually says this is a system, this is the way we're going to do things, and staff taking ownership of it and building it up from the floor. And you've got the abilities to be able to select whatever quality improvement methodology that meets your need, so don't necessarily have to just go into one camp. You can look along at a lot of things. Also, there's shared learning from the processes as well, so that's good. So good to see progress.
We talked, about the importance of the culture change that goes with that. That's, you'll always get your kind of early adopters who'll just do it because it's, they can see the value, but there'll always be the others who might take a bit longer, but you get, once you start getting the data and people can see the results, you get more and more kind of buy-in and ultimately the culture then starts to shift, and also so does the morale. And we talked about what we were talking about before about a stretched workforce. Everyone comes to work wanting to do a good job, but then things get in the way, and this is a way of kind of, I guess, improving that morale and allowing people to really see the value in what they're doing and be recognised for that.
I think the beauty of this local ownership, so being able to set together the aims and the overall structure, looking nationally for the program, but then saying, look, this is a bottoms-up approach. It's not something we've prepared earlier and we're just going to whip out and say, oh, here we are. But in fact, we're reliant on them to work together with us to build what needs to be built and to look at what's going to work more effectively locally. So there's the opportunity for that and the flexibility.
And I thought that one of the benefits is many of the approaches are involving the voice of lived experience right from the outset. And so you're actually balancing the experience of the staff who are providing services with the experience of people who are receiving the services in their family and whānau, etc., so that you have a richer if you like, data set, both of your number crunching data, but also of your qualitative information about particularly feelings. One of the things about the co-design approach is it's asking staff how they feel about the services that they're delivering, and it's asking consumers about what it feels to receive services, and family whānau members, what it feels like to be involved or not as involved as you would like to be, etc. And so that, with that engagement with feelings, feelings are the things that motivate behaviour, and so, it's really important for us to consider and look at that, because what we're trying to do through the QI approach is a significant change process, and actually to make significant change and to embed that change, really need to look at the attitudes, the behaviour and the culture within that environment that you're trying to change. And so it's that ABC approach of looking at those particular things, what influences those things, and what the possibilities are of utilising the QI approach to change those things.
As we keep stressing, we've deliberately added the co-design on the front end of our quality improvement for the program, so that we can ensure that we have the lived experience captured from the outset and there are processes in there. And I think this is one way of being more responsive to the needs of Māori as well.
When thinking about a QI approach, there's been quite a bit of comment before about, I guess, ideas and good practices coming up but disappearing when the people move. Also about the environment. We've talked a little bit about the DHB funding environment or different contexts. So one of the challenges, and perhaps we can even apply a QI methodology to this, is how we might create sustainable improvements.
Oh yeah, absolutely.
So that we consider the risk, the risks of sensitivity to individuals or to funding models or to change reorganisation. And we talked a little bit about maybe having to go beyond the organisation to create the structures so that they're sustainable. The broader you go, the less sensitive you are to factors changing within an environment. I used an analogy from the criminology field where a group of academics who were tightly coupled with police organisations, including Scotland, formed, I guess, a community outside the universities, and there's kind of pracademics, and they made a commitment to applying what they knew from evidence would work, and just really kept that as a vision, and it caused the science to grow and be sustained across the last 30 years. That's quite a different context, but it's still about people who have a vision, who have some evidence, who are looking at good practice, where there have been studies that show things work, where there have been evaluations, and maintaining that body of knowledge and maintaining the commitment and feeding off each other, even though they're from different organisations. So in a QI approach, we can have local QI. There's lots been talked about, people on the floor locally, but then a lot's been talked about the vulnerability of that to people changing.
That's a very good point.
To apply a QI methodology to your QI
Well, no,
program.
it is. In I think in medicine, things like reflective practice is kind of the same thing, isn't it? And as a doctor, I'm no longer godlike and just taking at my word. I have to accept feedback and reflect on that to try and continuously improve, as it were. So I suppose and you can tell that I've kind of been won over to this. This approach to me is a fundamentally better way of maintaining yourself and your skills, or a team and its skills and its practice, because it is about continuous reflection. I'll name drop. I met a guy called Scott Kelly, who is an astronaut. It was a meeting in Florida. I don't know if you're there, but he spoke very well about obviously the challenge of getting to the moon. Well, he didn't go to the moon. He's actually one of a twin, and his twin brother was also an astronaut. So he spent a year in the space station, and his twin brother was subject to lots of studies to see what the effect was on two twins, and one in space, one not. Anyway, he spoke about the challenge of achieving difficult things like flying a spaceship, and running a mental health service or improving care for mentally ill people is a similar challenge. But he talked about that actually, in terms of sustaining things, it relies on, the exact expression used was, you have to keep your eye on all the dials all the time and make small positive adjustments all the time just to get to where you want to go. And so that applies in any endeavour. It's not just about, oh, that's it, we've got it sussed, we're on the way now, and things just go wrong again. Small positive adjustments responding to reflection or data gets you to where you want to be. So I thought it was a very powerful, the fact that the guy's an astronaut, Christ. So it was made it powerful anyway. So, any final points before I get us to there is one last question, but don't worry, it's one for you to ponder. Any final points you want to mention?
I just think that one of the benefits of the QI approach right now is also the environment in which we are implementing the QI approach in mental health and addictions. So in the particular environment in this country where we've got a mental health inquiry taking place, where we are looking at how health is funded in the country anyway, and the distribution of resources with regards to health overall, but also even looking wider in terms of how do we measure what we value in this country. So I think it's really interesting development that we're not just going to look at our productivity and our GDP, but we're also going to look at the well-being of our communities, And there's a real relationship there between the well-being of our communities and, if you like, the well-being of our services that service the members of the community when they're unwell, And so I think within that whole structure and that whole environment where we're at in New Zealand right now, I think there are real opportunities for the QI approach to assist in us moving towards a society that we want to be and want to live in as New Zealanders.
For over 40 years I've worked in the mental health space, but now I'm working in a kaupapa Māori service that covers population health, primary care, and we've also got an addiction and mental health service there. And it just sort of dawned on me how much, and this is not a criticism, how we've kind of been in a bit of a bubble in the mental health field, and I'm appreciating the freedom of actually integrating mental health through all the services that I have and get people an understanding of mental health on a broader sense. And they're recognising now the importance. I mean, I've got 2 peers actually working for me, and they're having quite a profound impact on the organisation, bringing all sorts of different ideas and perspectives to our team. The point I'm trying to make here is that I think we have been in a bubble, and that we need to make sure the rest of the organisation, the rest of the system comes along with us as well, because I think some of the reasons why we lose some of that momentum and that leadership is because the rest of the system, our managers, actually don't understand what we're doing.
Yeah.
And I understand the reason why we might remain in that bubble, because it's actually it can be quite hostile as well, outside the bubble. But I think for us to, personally, it's my experience, for us to survive, we do need to get out of our bubble more and integrate ourselves more with the rest of the system.
Yeah. This is the question I was going to leave you with. You can give me an answer if you want, or you can just go away and think about it. So QI is about doing something right now. So usually at the end of meetings, you often talk about what you're doing next Tuesday, because you can't do it on a Monday, it'll be Tuesday. But so please have a think about where you sit within the structure, your role, and what are you actually going to do to support this work. I'm assuming that you've been won over with the argument that change and improvement's a good thing, that the QI approach is a good approach, it has more benefits than challenges, and that the challenges are surmountable. If you believe that, then hopefully you'll do something. If you don't believe it, well, then we might have failed. But and I'll leave you with one little slide I often show. This zero seclusion thing. Is it a good thing to set a very challenging and stretching aim? Well, more important or cleverer people than me thought it was a good idea to have a challenging aim. So I think New Zealand is actually, I think I agree. I've come to understand that there's lots of positive potential around, lots of good work happening already, and some really good, engaged people have given up some of their evening to be here. That's great. So I think all the fundamental blocks, at least as many as we had 5 years ago in Scotland, which I think we've achieved quite a bit. I think you might even be able to beat Scotland, not just at rugby. But so I think it's a good place to be, and I'm very pleased to be here to try and help a little bit. So thank you.